Well, I want to thank the Commission for the opportunity to address you. We have a great turnout considering we're competing with the Governor's budget message, which I think is happening right now, all of us, I think, have an interest in that document as well, but I'm glad we have the opportunity to be here. I also want to commend the Commission for naming Sherry as its newest member. She will bring an important behavioral health county-based services perspective to the Commission, and that is important because the county providers, which our network does not represent, are a critical piece of the North Country's behavioral health care service puzzle, or solution, I should say. And so that's great, Sherry. Glad you were able to join. Now, as you are looking at our, can we go to the first slide? Yeah, so this isn't exactly what I sent in. Karen warned me that they would be reformatting. So as we go through the slides, I want you to imagine that the background is not white with our lovely compass logo on there. Instead, it's a topographical map of the Adirondacks, faded in the background, and each of the bullets is actually a DEC trail marker for the bullets. So really we're trying to get you in the mood of this very rural and very wilderness related area of the state. So anyway, try to imagine that as we go through. Next slide, please. Okay, we should see 3 hospitals up there. Oh, sorry, that one. Okay, let's leave it up there. Okay. So we were founded in 1997 as part of the rollout of the statewide Rural Health Network program. We are one of 35 rural health networks that are across upstate New York. We have a staff of 4, and we have a staff of 4 FTEs and 5 individuals that work for the network. Our corporate office is in Saranac Lake, and it almost literally straddles the line between Franklin and Essex County, as the village of Saranac Lake is divided up between 3 townships and 2 counties. So we're right on the border. We are currently funded through contracts with DOH as a Rural Health Network. We also have a small contract with the Office of Mental Health and 2 contracts with 2 HUD Continuum of Care housing coalitions, and they serve 5 of our 7 counties. The member organizations pay annual dues that run between $250 and $1,500 per year. And in 2000, we developed a for-profit LLC called North Country Management Services, which contributes anywhere between 20 and 25% of our annual budget. We have a 9-member board elected from the membership, and they have a 6-year term limit. So there's constant moving through. Every member serves on at least 2 committees within the network. So we try and keep our folks both invested and engaged. Next slide, please. All 22 members are community-based not-for-profits. At this point, we do not have any county or state-based providers, and we'll talk about that a little bit more later on. In addition to the agencies and services listed on the slides, NCBH members include 1 FQHC and a Native American health clinic providing primary care, dental, mental health, substance use disorder, which we call SUD, and they have that as clinic services, as well as, I think it's a 16-bed residential program, which specifically focuses on the needs and cultural issues with regards to Native Americans. There's also a veterans residential program, which is currently being constructed. That's in Saranac Lake. That will be 25 beds. And we're hoping for ribbon cutting on that this spring, I think. Yep, and that's at St. Joe's. Next slide, please. Everybody brought a map, so did I. And you can't read anybody else's map, and you can't read mine. But basically, the little insignias and the little marks around the map indicate our service providers. We have 22 now, and you'll see that Hamilton County, which is kind of in the middle, is not shaded, but we do have 1 provider that's providing services in Hamilton County as well. If we were to take this map and look at referral patterns, because we're talking about integration here, so if we're talking about referral, you would see that those patterns generally run east and west. We have, since 1997, seen the North Country as one region, not as two regions split between the Albany catchment area and the Syracuse catchment area. We have recognized that the crown of New York State, the top counties, they are interacting east and west, more so than north and south. However, so you would see with regards to behavioral health service referrals that there's significantly east and west going to Ogdensburg, Watertown, Plattsburgh, and Saranac Lake. If you would look at primary care referrals, then you would begin to see some north and south, but only secondary to east and west because of the draw to Burlington, Vermont, and Fletcher Allen. Then strong, obviously, to Syracuse on our western side, and Glens Falls and Albany on the eastern side. Next slide, please. Good. Okay. We're going to get to EMRs and HIT in a little bit later. We are spending a lot of time and utilizing the grant that we get from the New York State Department of Health, getting ready for full Medicaid managed care, which will be implemented on July 1st, 2015. We've undertaken a regional alignment project, which we call RAP, which is a strategic planning process which will place participating NCBHN members in a forward-leaning position to deliver the highest quality behavioral health services at the highest value to payers and to primary care partners. And again, that's a key for us as kind of the, not the mainstream healthcare providers within healthcare, is that we need to identify who our customers are, and we see those as payers, and that will be changing over in the next several months, and also primary care, because we see a lot of services, especially if we do full implementation of the State Innovation Plan, primary care are going to be the gatekeepers, and we need to be there providing services to those primary care providers. As not all communities can possibly have all needed services, we will look to the Commission to make regulatory reform recommendations which will allow the flexibility needed to deliver the right service at the right price, the right place, and at the right time. And we will provide you written recommendations along those lines. And we've already heard that. We heard that from Linda, that there needs to be some new flexibility so that we can put services where they're needed. We hope the Commission will continue to recognize the relationship between stable housing and improved health outcomes. NCBHN has worked with local stakeholders over the last 10 years in 5 of our 7 counties to coordinate homeless prevention efforts. New York State housing funding arrives in communities through a wide variety of agencies and programs. We will advocate that the Commission recommend that funds that are tied to Medicaid redesign flow through the regional COCs. The regional COCs have been set up specifically to identify what the housing needs are, those that are associated with behavioral health and also criminal justice issues. They're there. They do a yearly point-in-time study, a yearly needs analysis, and they have generally a list of projects and priorities that are in the can ready to go. We would recommend that the Commission look at housing money coming through those regional COCs. Finally, we work with other rural health networks in the North Country to address the behavioral health issues that have been identified in each of the county's prevention agendas. Next slide, please. The North Country Behavioral Healthcare Network is now partnering with Fort Drum Regional Health Planning Organization and the Adirondack Health Institute in an effort to gain funding to advance HIT and electronic health records within the behavioral health community. We see the evolution of primary care as an opportunity to develop new markets for the timely and efficient delivery of behavioral health services. We think that if Medicaid managed care is successful, that private insurance companies and with new mandates included in the ACA will also want to look at innovative behavioral health services. The development of ACOs will present well-organized networks of behavioral health care providers with opportunities to integrate with primary care and hospitals to reduce avoidable admissions and readmissions. The effective delivery of behavioral health services is also a critical component in reducing recidivism within our criminal justice system. Uh-oh, I lost my place. And is another opportunity to help bend the public dollar cost curve. But we have a lot of work to do. Although we have 22 providers that have been sitting, most of which have been sitting around the table, gaining trust and getting to know each other and dealing with competition issues for the last 15 years, we still have a long ways to go. We are still not well organized. I was very interested to hear our presenter on the physician practice organization. We are looking at that, but our members are not at a comfort level that we would organize and incorporate in a way that we can negotiate as a single entity. Although we are hearing from primary care and from payers that they would be very open to that, rather than dealing with multiple individual organizations for a group to come with a single solution. But we're working on it. We still have a huge issue with connectivity with regards to electronic health records, and we'll talk about that. And our relationship with mainstream primary care really is only in its earliest stages. We have a beginning relationship with AHI, a beginning relationship formally with Fort Drum Regional Health Planning, and we need to reach out to the physician group that presented earlier. We've only had one meeting with the health insurance plan so far to get ready for the Medicaid managed care, and we have much work to do with them over the next 12 to 16 months. Next slide. Another map, just an indication of where we need to go. The other thing is, with 7 counties, we don't have the critical mass that we need either. We still need to tell our story and our vision to a larger catchment area, and we need to revisit as an internal issue within our organization how we want to relate to and be more welcoming to our county and state provider partners to see if there's a way that they can also participate within the network. Next slide. As I mentioned, we have the beginning relationship with Fort Drum and with the Adirondack Health Institute, and we've applied for HRSA money under the Network Development Grant program to try to advance our HIT and electronic health record initiative. Under that initiative, we would be providing technical assistance support services to include workflow analysis, project management, staff training to implement electronic health records in behavioral health settings, connectivity to the RIOs and to the Shiny, technical assistance with consent management, privacy and security issues, and strategic planning to achieve meaningful use. We are advocating that DOH really look carefully at the DSRIP and the waiver exclusion on EHR and HIT. What exactly is CMS saying we can do and we can't do? Because if it's just software and hardware, there's lots of other things, that list I just read, that we still need to do within the community and we can do to integrate with primary care that's separate from software and hardware, but still will advance EHR and HIT. I don't know what those limitations are, but I really would advocate and hope the Commission would that the DOH look at that and to the extent possible really stretch the envelope and get in as much as we can to support this one part of the industry that has not been addressed with regards to electronic health record and connectivity with primary care and with the RIOs. With that, I'm done, and I would be happy to answer any questions.
Thank you, Barry, very much. Let me open up for question time. To both Linda and Barry, I think the context was terrific. I thank you for the perspective. Both of you mentioned regulatory issues. We had about 400 pages of pre-reading, and despite that, there were some missing specifics. So both of you mentioned the regulatory, and if you could come forward with specifics, some of us would be grateful.
Yep, it's in our plan to do that. Great.
Yes, you referenced the prison population and the rates of recidivism, and that's been something that's kind of intrigued me for a while, that, there's 5 prisons in Jefferson and St. Lawrence counties alone, and then I was just skiing in Malone for the weekend and, can see the prisons from the hotel. And, outside of forensic issues that would require someone to go to Marcy, what is being done for docs to work with OMH, and are there economies of scale, or is there a better model, when we talk about those issues while someone is incarcerated, not even talking about the county levels where, the financing is such that there really are no programs in our county jails. And even though, I've heard testimony because of the Regional Center of Excellence planning process from all of our county sheriffs about, the majority of their population are on, drugs for mental illness. And, that would be something interesting to look at, as there's a significant, inmate population or offender population in the North Country. If you look at, all across us, that's, I think, a part of the puzzle maybe we need to understand a little bit better. And is there dollars to be saved? Not maybe just OMH, or, maybe there's docs money that could also be saved in this process.
So I think, Assemblywoman, I was specifically actually talking about the county, at the county level, and the issue of early intervention for people that are entering the criminal justice system, either with kind of the nonviolent drug or alcohol related, criminal, arrest, whatever it was, but it was heavily influenced by the fact that they have an unresolved issue with some sort of substance. So I was actually kind of talking about, diversion programs, and also for programs that could be delivered within the county jail system rather than the state prison system. I have to admit that if once you get to that state prison system, you're well beyond my pay grade. So I don't know, but I bet Sherry Gillette has a lot of thoughts about that, because she deals with that at the county level.
Sorry, I would just add that county jail programs are unlicensed and largely determined by the county. Some counties have a doc nurse practitioner go in 2 hours a week. That's the extent of the mental health program. Other counties have an entire team in there, 6 or 8 people who do release planning. They know when the person's going to be released. They ensure that the person has housing. They ensure that the person has medication. So it's very unique. It's an unlicensed program, and it's really up to every county to plan and to allocate the funding, the OMH state aid dollars there, and we'd be happy to show counties different models which have been successful. Other diversion programs, the boutique courts, mental health, drug courts have been very successful in diversion. These are programs where the person goes in front of the judge every week and ensures that they are doing X, Y, and Z, and the alternative, if they're not doing X, Y, and Z, like taking their medication, going to their therapy groups, working part-time, if they're not doing that, they go to jail. So it's actually an alternative, and again, we'd be happy to show counties how to work with the unified court system to set those up. They've been quite remarkable, actually.
Yeah, I just can't resist one more item I think that comes under the purview of this commission. You mentioned, Barry, the ontological question. Is there one North Country, or are there 2? Right. And my experience has been really very little dialogue and conversation and interaction between the East Slope and the West Slope, and matching patients going South Albany or south to Syracuse. Even though medical marijuana got all the attention in the governor's State of the State, he also mentioned the establishment of regional health improvement collaboratives, something that I think will be an outcome of what we do. We will go away in favor of a RIC or 2 RICs. And so I think one key recommendation for us is, do we see the cultural affinity and the rural nature of the North Country being as one, and therefore should be addressed as one unit? Or is there so much distance that we really have to divide in 2 to be able to address the local needs effectively at each place? And again, we'd just like to put that on our agenda for tomorrow and then in the next meeting and the next, because I think that's another area that we do need to address.
Okay, well, thank you. Thank you for that presentation.